from the American Academy of Pediatrics.
More than 2.8 million Americans become ill with antimicrobial-resistant infections each year.
One reason why is the misuse of antibiotics in agriculture.
Antibiotic use in farm animals and also in aquaculture leads to antibiotic-resistant bacteria in the environment, in the runoff, in water supplies, in meats, for example, that we might purchase from the grocery store.
But first, we have research on everything from RSV to cholesterol screening to ChatGPT.
Part of me hates to think that AI is going to take over our role in terms of answering questions to patients, but really you could see how this technology could really augment what's going on.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Malinky.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a research roundup from the journal Pediatrics.
We are coming up on the holiday season, and I feel like I actually have a ton to be thankful for. Specifically, it's baby Zelda's first Thanksgiving and maybe her first time trying turkey. Having little kids makes the holidays really fun for me.
I miss those days, Joanna. And wow, to try turkey again for the first time. Imagine.
I get the sense, do you not like turkey?
Look, I'm just saying, you should tell Zelda it doesn't get any better as she gets older. This is as good as turkey will ever be.
I suppose the first taste is the best, but everybody loves leftovers, so we'll see. I'll let you know how she enjoys it. Who knows?
You know what? You're right. It does get marginally better the second day.
Yeah.
I'm so grateful that my kids want to spend the holidays with us. Of course, we now have to fly 3 of them back home, but it is so worth it.
Well, David, this is a time on the podcast where we get to get cozy with one of our regular guests who's like family to us.
It's got to be an edition of First Up. And I've been keeping track of our episodes, so I know today is with the Deputy Editor of Pediatrics, Dr. Alex Kemper. Alex, welcome.
David, Joanna, so happy to be here. You both make me feel so warm, inviting me here over Thanksgiving.
Oh, well, thanks for joining us this November. And let's get into the articles. So, Alex, in the past, you've been my go-to for children's books. I recently read The Wild Robot with my kids, and it's all about a robot that learns to live in the wild, and it's just a really cool take on artificial intelligence. As it turns out, Pediatrics has its own fascinating article on artificial intelligence and communicating with families in the PICU. Can you give us a summary of this wild take on using ChatGPT?
We do have a really interesting article on ChatGPT and the use of artificial intelligence to help families answer questions that they might come up with. So this study is entitled Using ChatGPT to Provide Patient-Specific Answers to Parental Questions in the PICU. And it's by Hunter and colleagues. Dr. Hunter is at Texas Children's Hospital, but this is really a multi-site project with investigators from all over. And it's essentially a simulation study. What they did was they developed assessment and plans for typical patients that might be in the PICU. So patients with respiratory failure, septic shock, and status epilepticus. And then once they developed those assessment and plans, they also developed 8 typical kinds of questions that might be in the mind of parents whose children have those conditions in the PICU. And then they looked at how well ChatGPT, using the question and the information about the patient's status, would generate a result that was empathetic to the families and that was spot on with the kind of answer. And surprisingly, or maybe not so surprisingly to those who've been following the evolution of artificial intelligence, it did really well. So the questions, the answers rather from ChatGPT didn't cause any harm, which is good. And in general, they were empathetic and they were spot on with the response. Sometimes the answers really dug into the patient's specific information and sometimes it didn't. But the bottom line was that it did really well. I think the question for me is, what does this mean for the future? The clinician or the physician bond with the patient, the role of the care teams is so important when you have a child with critical illness, or even when a child doesn't have critical illness. So part of me hates to think that AI is going to take over our role in terms of answering questions to patients. But really, you could see how this technology could really augment what's going on.
Well, as a pediatric hospitalist, I am dreading the respiratory syncytial virus season, and it is coming. For pediatricians, this virus is more than a cold. It's a headache and a heartache to care for babies and children who get sick from it. But I've been giving nirsevimab now for over a month. Is it going to keep kids out of the hospital this year?
Well, I got good news for you, David. We're publishing a study this month entitled RSV Neutralizing Antibodies Following Nirsevimab and Palivizumab Dosing. This study was led by Deidre Wilkins and colleagues. Most of the authors were with AstraZeneca, the pharmaceutical company, and it's a secondary analysis of the Medley study, which is a large randomized study. And what they did was they looked at a single dose of nirsevimab followed by 4 monthly placebo doses or 5 monthly doses of palivizumab through the RSV season. And their question was, is the RSV neutralizing antibodies persistent with the 1 dose of nirsevimab compared to the regular full course of palivizumab? And the great news is that it is, that overall the titers are about 10 times higher with nirsevimab compared to palivizumab over the course of the RSV season. And so this is another great piece of evidence that shows that 1 dose of nirsevimab really is protective. Now, the study outcomes aren't patient-related in terms of who got sick and who didn't, but we know that there's a strong association between neutralizing antibodies and who actually develops RSV. So I think that this is great for us as clinicians when we recommend nirsevimab compared to palivizumab, being able to reassure families that it lasts. And let's face it, I know that in our clinical practice, it's hard to make sure that everybody gets all the doses of palivizumab in the first place. This is so much easier for families to give the 1 dose of nirsevimab and be set for the season compared to having to give those monthly doses of palivizumab. This is another thing that makes me really excited and energized about nirsevimab. And like you, we've been giving it over the past month.
Well, David spoke about how RSV can cause him heartache, and another thing that is not great for heart health is cholesterol. So we want these levels to be low in kids, but how should we be screening for them, and do we even need to be?
Joanna, this is like the $10 million question, and it's something that I've thought about a lot. And I think it's important to recognize that there's significant debate about the role of measuring lipids during childhood. So the U.S. Preventive Services Task Force, which has a pretty high bar in terms of looking at evidence of benefits and harms, found that the current evidence is insufficient to assess the balance of benefits and harms of screening for lipid disorders in children and adolescents to 20 years of age. That doesn't necessarily mean that there's not a benefit. It just means that using the task force methods, it was impossible to resolve the issue. That's in contrast to the periodicity schedule and Bright Futures, what the AAP recommends, which is that screening for dyslipidemia should occur once between 9 and 11 years of age, and then again once between 17 and 21 years of age. For all patients, it's a universal screening recommendation. The AAP uses a slightly different approach to evidence and considers some observational studies that the U.S. Preventive Services Task Force might not use. So entering into this is a study that we are releasing this month entitled Predictors in Youth of Adult Cardiovascular Event. This study was led by Dr. Niotio, who is at the University of Turku in Finland, but has a cast of co-authors from really all over the world, including Australia, the United States, and the United Kingdom. And what they did was they put together 7 different large longitudinal cohort studies, including well more than 11,000 patients. And they looked at risk measurement for cardiovascular events between the ages of 12 and 19, including things like obesity, BMI, whether or not they smoke, lipid levels, all the kinds of things that we think about in terms of future cardiovascular risk. And then they followed these patients forward into adulthood to see who actually had cardiovascular events. And when I say cardiovascular events, I'm thinking about things like myocardial infarction, strokes, TIAs, peripheral artery disease. It was really a wide range of cardiovascular events. Now, the thing that's really interesting is that they compared a prediction model that didn't need laboratory testing. So it had age, sex, blood pressure, body mass index, and smoking. And then they developed another model that included lipids like total cholesterol and triglycerides. And guess what? Both the models had the same predictive value. So whether or not you knew the lipids or you didn't know the lipids, if you looked at those other factors, you could do a reasonably good job in predicting future cardiovascular risk. So what does that mean? Does that mean that we shouldn't measure lipids anymore and that we should just focus on the information that we would otherwise have at hand? You know, on one level, that might be the take-home message, but we had an accompanying commentary by Dr. Samuel Gidding, who's at the Geisinger Health System, who raises a number of really important issues. And one of them is if we use the information at hand to predict future cardiovascular risk without measuring lipid levels, we won't be able to identify patients who are at risk of familial hypercholesterolemia, because it turns out just assessing family history for familial hypercholesterolemia can miss a lot of patients. And familial hypercholesterolemia, in the grand scheme of things, is not that rare. It affects about 1 in 250, 1 in 300 of our patients. So although lipids might not be necessary for predicting future cardiovascular risk in general, it would miss things like familial hypercholesterolemia. There are also other benefits of having lipid levels in terms of talking to families and explaining risk and putting things into context. So, you know, this isn't the final answer, but it raises a lot of interesting and important questions. I do want to end this part, though, by reminding everyone again that the periodicity schedule does recommend routine screening, and that you should still think about other risk factors. If there's like a strong family history that's suggestive of early heart disease, even getting cholesterol levels as young as 2 years of age might be appropriate. And again, this conversation doesn't apply to patients with obesity that you might be worried about other issues and those kinds of things. So we're just talking about universal screening in unselected patients. But it just goes to show how complicated these things are. And of course, it's going to be really difficult to resolve these issues because we can't do a randomized trial of screening lipids in children and then wait 50 years to see what happens. Certainly, I'm not going to be around when the results of that kind of study would be out there.
Well, Alex, we are thankful that you're around today to help us sort through some of these complicated issues and talk about the implications. And we are excited to have you always telling us about all the latest and greatest studies in pediatrics.
Thank you, David.
Alex, we often do takeaways at the end of episodes, but not when we do First Up. But since the holiday season's coming and we talked about it, is there anything that you're thankful for as this year ends?
You know, I love Thanksgiving, and I like to take the moment to reflect on things. And of course, I'm thankful for the work that you all do and the colleagues that I get to work with. But I'm also thankful for my family. I look forward to getting together with my wife and my son for Thanksgiving. My daughter recently moved to Australia, so she's 10,000 miles away, and we won't be seeing her for Thanksgiving. But through the miracle of Zoom and somehow managing to get the 15-hour time difference right, we'll also get to see her that way as well.
Well, I am looking forward to seeing my kids. You're looking forward to seeing yours. Joanna gets to see hers all the time. So let's all be thankful for our families. And in the meantime, for these articles and more, visit our website at aap.org/podcast.
Coming up, we'll look at how the use of antibiotics in agriculture has downstream effects on children's health.
Joanna, what did you and your parents talk about around the dinner table when you were a kid?
Oh, wow. No one has asked me that in a while. From what I remember, I think it was the typical stuff, commenting on the food, recounting our days, figuring out who's responsible to walk the dog at night. What about you, David?
Oh, yeah, all that. School, the news, antibiotic stewardship.
Wait, antibiotic stewardship? I don't think that's something all families are talking about.
Wait, just me? Well, my dad's a pediatrician, and he was worried about antibiotic resistance before it was cool. When I was young, he was like, look both ways before you cross the street, listen to your teachers, and never treat a viral illness with Augmentin.
Yeah, I'm pretty sure most families don't talk about that at the dinner table. Maybe the only infectious concern at our dinner table was when we would pass the food to the dog and they'd lick our hands, and my mom would be like, make sure you wash your hands.
Well, you did then talk about veterinary antibiotic stewardship. Admit it. And now the AAP is also talking about it in a recent technical report from the Committee on Infectious Diseases and the Council on Environmental Health and Climate Change, entitled Use of Antibiotics in Animal Agriculture, Implications in Pediatrics.
While we might not be at a dinner table, we did invite one of the authors to join us to talk about this report, Dr. Ritu Banerjee. Dr. Banerjee is a professor of pediatrics and pediatric infectious diseases at Vanderbilt University Medical Center and is the medical director of their pediatric antimicrobial stewardship program. Ritu, welcome to the show.
Thank you so much.
So I think you heard us talking about David's dad. Was he right to be so concerned about antibiotic resistance that he would talk about it at the dinner table? I mean, how big a problem is it in pediatrics?
Yeah, David's dad was totally spot on. We absolutely should be worried about antibiotic-resistant infections. They affect children as well as adults. And one of the biggest areas where we can do better about this is not treating viral infections with antibiotics. And I also do want to say that I do speak about antibiotic stewardship with my own kids at the dinner table.
So why should we care about antibiotic use in farm animals? I've never had a cow sneeze on me.
Neither have I, actually, but antibiotic use in farm animals and also in aquaculture leads to antibiotic-resistant bacteria in the environment, in the runoff, in water supplies, in meats, for example, that we might purchase from the grocery store. And that in turn can lead to antibiotic-resistant bacteria colonizing or infecting humans, including children. And as we all know, children are not great at washing their hands, and a lot of what they touch goes in their mouth, their dirty hands, their toys, etc. So they're particularly susceptible to acquiring bacteria that's in the environment.
I know none of our listeners is likely a veterinarian, but are antibiotics used in animals the same way they're used in people, or are there differences?
Yeah, that's a great question. Previously in the United States, there was a ton of antibiotics used in feed, animal feed, because people realized animals grew bigger and faster if you put antibiotics in their feed. But of course, that has a lot of downstream side effects, including leading to selection and propagation of antibiotic-resistant bacteria in the animals and in their environment. And so we don't do that anymore. The FDA actually, in recent years, has created regulation, passed laws that actually say you should not be using antibiotics in the feed of farm animals.
So if there are now restrictions in putting antibiotics in feed for animals, where are they getting these antibiotics?
Yeah, well, so now antibiotics that are used in animals require veterinarian oversight, which is a very good thing. Just the same way, you can't get antibiotics over the counter in the United States. You need them with a clinician's prescription. The same thing goes with antibiotics that are used in farm animals. They're used to treat infections in animals, just like they're used to treat infections in people. Sometimes they're used at a population level or a herd level to prevent infections. And sometimes, in rare instances, they're used to actually control spread of infection in large groups of animals. But the prevention and the control use of antibiotics are really restricted and require veterinary oversight, which they didn't in the past.
And I want to get deeper into the weeds here. When animals are exposed to these antibiotics, how does the resistance form? And are the mechanisms the same ones that we talk about in human medicine?
Yeah, remarkably, a lot of the antibiotics that have historically been used in animals are medically important antibiotics, meaning they're in the same classes of drugs that we use to treat infections in people. And so the mechanisms that bacteria have to develop resistance to these classes of antibiotics are the same often in animals and in people.
How do resistant organisms make the jump from animals to humans?
Sometimes from direct contact. For example, if bacteria that are on the surface of the animals or in the intestines of the animals contaminate the environment, the soil, the vegetables that are grown in the soil, the water that's around, in the area, all of that can make their way into people through direct contact with the environment, the water, the soil, the dirt, but also through contact with the meat. So farm animals that are raised for food, if they're not cooked very well, bacteria that we commonly hear of as causing food poisoning, like E. coli, Campylobacter, Salmonella, can be transmitted from the food into people by ingesting poorly cooked animal meat.
And then what about with produce?
Yeah. So if the vegetables are contaminated with soil or water that has the antibiotic resistant bacteria in them, if they're not washed very well, or if they're not cooked, then the bacteria can also go from the food into the people that ingest the food.
And Joanna talked earlier about her family's dog licking her hands at dinner when she was a child. What about household pets? Do we have to be concerned with our cats, dogs, lizards, birds, otherwise?
In general, they're less of a concern than farm animals, but antibiotic use should be very judicious and only given to household domestic animals and pets when needed to treat infection, not, overused in household pets either, because they can also get colonized and infected with antibiotic resistant bacteria that are harder to kill with our usual antibiotics. And then, of course, children who love to play with pets and who are not great at hand washing can easily acquire strains of resistant bacteria from household pets. So the risk is lower, but the risk is not zero with household pets.
And as an ID specialist, do you worry about particular zoonotic infections? Because you've been mentioning bacteria.
Well, the antibiotic resistance problem is primarily in bacteria. In terms of resistant species that are easily transmitted from animals to humans, we worry about enteric bacteria a lot, like E. coli, Salmonella, Campylobacter, that live in the guts of animals and also of humans. But also there have been reports of methicillin-resistant Staph aureus, or MRSA, which is one of the superbugs that people hear about a lot in the news. They have been transmitted from animals like pigs to farm workers who have then transmitted that to their household members. So pretty much all different kinds of bacteria can be spread from animals to humans.
And you had mentioned FDA regulations restricting the use of antibiotics in animal feed. Are there other steps that government or industry is taking to address this issue?
Yeah. So There's a lot of advocacy now to encourage the government to do even more. They've done a great thing, which is restricting antibiotic use in animal feed. But they can do more things like restrict medically important antibiotics so that they're not used at all in animals. And in fact, they've taken great strides in doing things like that in the European Union. They can also limit the length of time that animals, when they are prescribed antibiotics, actually receive the antibiotics. There's a big movement in human medicine now that shorter treatment courses are better than longer treatment courses in terms of side effects and selection of resistance, et cetera. So the same holds true for shortening durations of antibiotic treatment in animals when they get antibiotics. And then I think that we have not done a great job historically of tracking how we're using antibiotics in food animals. So decades ago, we were not tracking how we were using antibiotics in humans very well either. Now, with the emergence of antibiotic stewardship programs, that's one of the biggest things we do in hospitals and also in outpatient clinics is track what antibiotics we're using and how we're using them. So we need to be doing the same thing in terms of tracking how we're using antibiotics in farm animals. Then we also need to share that information with regulatory agencies and the public.
And as pediatricians, how do we counsel families about this topic?
Yeah. So one of the things that I tell my patients is, antibiotic resistance is a really complicated problem that requires a very complicated solution, but we can focus on what we can modify as individuals and households. So I say, when you go to the grocery store, try really hard to buy products, produce, and meat that's raised without antibiotics. Also, when you or your child or other household member is sick with a cold, just remember that most colds are caused by viruses. They are not treated by antibiotics. So if you are prescribed an antibiotic by a healthcare provider, just be your own best advocate and ask, do I really need this antibiotic? Or is it just a virus that will run its course and get better in a few days? And then the other really important things are good hand hygiene. So washing your hands really well when you're sick with a cold, or when you're, playing with your household pet, or when you're handling food and preparing food. And also remember to cook your food, especially meats, very well.
Well, Dr. Banerjee, this has been an incredibly enlightening conversation. Before our listeners go read this technical report, do you have any last takeaways to share?
So I think there's a lot of positive steps the FDA has made in recent years to restrict unnecessary antibiotic use in farm animals. We've also made tremendous strides in reducing unnecessary antibiotic use in humans in our country. But there's more that we can do. And at a personal level, here are some things. Just remember, we can advocate for our own health by not expecting antibiotics every time we go in to see a clinician for a sick visit. And we can also, encourage industry to grow animals without antibiotics by supporting and purchasing antibiotic-free products, produce and meat in place of products that are grown with antibiotics.
Dr. Ritu Banerjee, thank you so much for talking with us today.
Thanks very much.
To read the technical report, Use of Antibiotics in Animal Agriculture, Implications for Pediatrics, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, we just finished with Halloween, and at your kids' ages, they're going to be involved and excited. But Christy and I were actually caught off guard when our oldest daughter texted us, "You guys haven't gotten pumpkins yet, have you?" Because she wanted to go with us to the same pumpkin patch we always go to and bring her dog, and she wanted to come carve a pumpkin with us on Halloween. And I'm just delighted that at age 26, we can still involve her in these rituals.
Oh, we had such a good time on Halloween, so I'll make that my say. It's actually one of my favorite holidays in Philadelphia because they close down streets and there's so many houses that give out so much candy and the kids are all out in costume, dancing. I mean, it's a real party. I got to invite you up. Maybe I'll invite your oldest daughter. She'll have a good time.
Please. And you guys have that whole mummers thing, which I think has nothing to do with Halloween. But...
That's a New Year's thing, so we'll talk about that on New Year's. Yeah.
Okay, we're saving it. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer. And Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at inequities in school suspension and expulsion.
We'll talk to the authors of a new policy statement, Drs. Susanna Jane and Ryan Pedrez. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Balinki. Thanks for listening.